Good afternoon. My name is Harshdeep Kohli, and I will be presenting my team's diagnostic analysis around the NHS capacity and utilization of services. This presentation is intended for NHS's leadership team. Please note, due to poor data quality practices, it was difficult to find actionable insights from the data, so please interpret this analysis with care. Also, a Twitter analysis was conducted, but as this was not directly related to my area of focus and didn't prove to be valuable, I decided not to include it in this presentation. However, with cleaned, ethical hashtag analysis, we could track engagement across users to gather insights about capacity and utilization of NHS services. This analysis was conducted using Python, known for its ability to handle vast amount of data and automate processes. My project is also hosted on GitHub, which is one of the largest coding communities and allows my project to be reproduced and promote collaboration with industry professionals. This presentation will focus on the two main business questions that the NHS has asked me to evaluate, which are: has there been adequate staff and capacity in the networks? What was the actual utilization of resources? These questions were raised due to the problem of missed appointments and inefficient allocation of resources. These questions will be explored in greater detail by understanding appointment modes, healthcare professional types, and wait times, as they tell us how healthcare was delivered, and any variations in attendance rates can be tracked back to those variables. Starting with the relationship between average wait time and missed appointments, there is a strong positive correlation between average wait time and missed appointment rate. A statistical test showed a significant positive correlation between these two variables. This means higher wait times are driving more missed appointments. In general, 91% of appointments are attended. However, the 4% missed appointments shouldn't be ignored. In 2019, a report on the cost of missed appointments calculated the following. Each appointment cost an average of £30, putting the total cost to the NHS at more than £216 million, on top of the disruption for staff and fellow patients that would pay for the annual salary of 2,325 full-time GPs and the annual salary of 8,424 full-time community nurses. Applying that £30 missed appointment metric to our data, then the 4% missed appointments could cost the NHS around £927 million, an eye-watering figure. However, if we look at missed appointment rates per region, we can see that North West and London have the two highest did not attend rates. However, these regions have the lowest average wait time, suggesting disparities between appointment wait times and did not attend rates across different NHS regions. This could be due to poor data quality practices in these regions, and therefore more granular data needs to be collected to understand this issue. But how does identifying trends in did not attend rates benefit the NHS? The 2023 NHS report stated that reducing did not attend rates will have the primary benefit of better releasing capacity, which can be used to clear backlogs and reduce waiting times. Let's now look at appointments by appointment mode. 59% of appointments are delivered face-to-face and 36% by telephone. In the first lockdown, we can see a dramatic spike in telephone appointments, going from circa 15% in Jan 20 to even more common than face-to-face appointments at circa 50% in April 20. Since the first lockdown, face-to-face appointments have increased and telephone appointments have seen a decline. Attendance is generally high for both of these modes, but after the first lockdown we can see a dip in face-to-face attendance, whereas telephone attendance remained consistent, suggesting telephone appointments are more reliable. Let's now look at the attendance by wait time. Attendance rates are higher for telephone appointments across all wait times, but as wait time increases, the gap between telephone attendance and face-to-face attendance also increases. This suggests telephone appointments have a higher chance of attendance, and earlier booked appointments relate to higher attendance rates. This insight is also supported by average wait times for telephone appointments being more than half to that of face-to-face appointments. Referring back to the business goal, This insight tells us more telephone appointments should be implemented to improve total attendance. To measure success, the NHS should track attendance rates before and after increasing telephone appointment volumes, then compare it to the baseline telephone attendance rate and measure if more telephone appointments are achieving the desired effect. Let's now look at appointments by healthcare professional types. GPs deliver 51% of appointments compared to 46% for other practice staff. Disregarding the unknown healthcare professional type, which was due to poor data quality issues, the above graph shows similar appointment trends for both HCP types, with spikes and dips during the same periods. We also observe a huge dip in the first lockdown for both, but an interesting spike at the end of the third lockdown for both too. Also, during the autumn period, we observe a spike in other practice staff appointments surpassing GPs, suggesting their vital need to reduce pressure from GPs during the busy season. It would also be beneficial to have the data at a more granular level to inform us of which healthcare professional delivered the appointment for a deeper analysis. Another observation is the ratio of appointments by HCP type and appointment mode. This graph shows us that GPs take proportionally more telephone appointments than face-to-face appointments, but there is a wider gap in the ratio for other practice staff, where we can see that face-to-face appointments are the more popular one. Looking at did not attend rates, we can see that other practice staff have more than double the did not attend rate compared to GPs. This is again supported by other practice staff having more than double the average wait time than that of GPs. This suggests that there are inefficiencies in appointments conducted by other practice staff and further investigation is needed. Could other practice staff take on more telephone appointments to help them increase attendance rates, as we know telephone appointments are better attended? A good example of this is how NHS Pickering Medical Practice reduced routine GP appointment waiting times by 47%. They did this by offering patients telephone appointments first rather than face-to-face. They also claim that for every one face-to-face appointment, a GP can deal with 2 patient calls, freeing up capacity to deal with more patients. Finally, let's look at appointment utilization. Tuesday is the day of the week with the most appointments at 20.9%, followed by Monday at 20.2%, which begs the question if earlier week appointments can be moved to later in the week. However, looking at the time series graph, Monday is generally busier, but the totals are brought down by public holidays. Looking at monthly utilization, I was given a figure of 1.2 million appointments per day as the maximum daily capacity for the NHS, which was multiplied by 30 to get the monthly capacity. It's important to note that maximum capacity utilization was 84.5% in November 21 and an average capacity utilization of 69% for the whole period. Analyzing the utilization at a daily level by using the national categories dataset shows that there were many periods where utilization exceeded capacity, with dips representing weekends and holidays. In summary, there were 175 out of the 334 days analyzed where utilization exceeded capacity, equivalent to 52%. Looking deeper by day of the week, we can see that Monday and Tuesday emerged as the most common days where capacity was exceeded, and a focus on improving capacity on these days is needed. Referring back to our business goal, a maximum utilization of 84.5% suggests that yes, there was adequate capacity for the period in question, but based on our average capacity utilization of 69%, this suggests that NHS is on average operating 31% under capacity and possibly reflects wasted resources. But it is important to realize that this period was heavily impacted by lockdowns, so understanding of resources and utilization is a complex issue, and more data is needed to make a fair judgment. The metadata highlights that the data was not designed for analysis, lacking national standards for data entry, resulting in widespread data quality issues. Here are my analytical recommendations, which I believe would help us better understand reasons for missed appointments. We need more data, especially at a more granular level, i.e. information on the role of the healthcare professional associated with the appointment. Improving data quality issues, i.e. no unknown, unmapped values. reporting at ICB level and standardized to monthly level for direct comparison of KPIs, enrich data with demographics and regional information to tailor interventions to customer segments, predictive analytics to determine the likelihood of future missed appointments. In conclusion, here are my key takeaways for the NHS based on the data. Incentivize more telephone appointments. In general, we can see that attendance for telephone appointments is greater. The limitation is that we don't know what groups of patients prefer telephone appointments, but we could consider offering telephone appointments for groups more likely to miss face-to-face appointments, e.g., younger patients or those with mobility issues. Measure success by comparing attendance rates prior to expanding telephone appointment volumes and after expanding. Keep time between booking and appointment short, as these appointments are more likely to be attended. Increase staff capacity earlier in the week, as demand is highest on Mondays and Tuesdays. Monitor staff-specific did not attend rates. Other practice staff have higher did not attend rates and average wait times than GPs, but they conduct proportionally more face-to-face appointments, to consider expanding telephone appointments for them to reduce missed appointments. Finally, Twitter data proved to be less useful, but potential insights can be unlocked through cleaned, ethical analysis using relevant hashtags.